So we are going to the next final case in another theater. Can I have the history, please? So as you see on the screen, he's a young male, 26-year-old with chronic calcific pancreatitis and type 3 diabetes. Came with pain abdomen, and when we evaluated, found pancreatic large calculus in the head of pancreatic duct with dilated main pancreatic duct. So he underwent pancreatic lithotripsy, as you see on the screen, pre and post. So we'll just take a minute to show how this lithotripsy is being done in our unit. Can I have the video, please? As you see here, actually, I have Dr. Santosh with me, who leads the anesthesia team, and he is doing the epidural anesthesia, which will be done. And this is a Delta 3 Dornier machine, which is used for lithotripsy for both pancreatic and biliary calculi. This is a very high-end machine, which has got utmost safety with minimum shocks being used compared to the earlier versions of Dornier. And as Dr. Vinod is a dedicated person who does this work in our unit. And we usually do this pancreatic lithotripsy, and then depending on the size of the pancreatic duct, we go for a ERCP and to put a stent or not. So now I go straight away into the case. I'm using again.
Also, you can see from the timing on the lithotripsy machine that is actually I've done about half an hour before. So on the same day, lithotripsy and ERCP is done, Asma.
Yeah. And I'm using a Pentax duodenoscope with a Boston Scientific sphincterotomy. So I see here, I am just trying to go and get deep into the pancreatic duct to cannulate. Yeah. Okay. Yeah. So please push the wire. As you see here, I'm trying to get into the pancreatic duct because there was this head stone in the head. We pulverized that.
Calculi are completely gone. Don't see much on fluoroscopy in terms of calculi. So Rakesh is trying to gently place the sphincterotome towards the pancreatic duct. And whether I don't know, a small amount of injection will help at this stage, Rakesh.
Yeah, just put a little bit of contrast.
So we know where the direction is.
1 second. I'll just reposition myself. You can just put some water.
Water there, and that's the reason why the opening is not so obvious here.
Okay.
But once the edema comes down,
push the wire. Yeah. I'm in. Okay, just position myself.
To clean the papillary orifice.
Yeah. Can you just put some water and flush it?
So he's going to clean the papillary orifice and see exactly. You can see the orifice down there. Yeah.
1 second. I'll just position. So what happens is post CSW, they have a little bit of edema of the tissue.
How nicely placed.
Yeah.
Now you're deep in. I think maybe at this time,
can you gently
would help. Some injection would help. Not very powerfully, you have to give it
a little bit of contrast, please.
So that we'll know the anatomy here.
I just want to ask you here, are you planning to do a selective pancreatic sphincterotomy? Or?
Yes. So that the goal in this case is to do a deep cannulation with the wire to get into the pancreatic duct. And then after that, do a selective pancreatic sphincterotomy and then put a balloon to sweep out all the remaining fragments. So this is the goal. And you can see one of the issues here, of course, is that the wire is not going very easily deep into the pancreatic duct. So Rakesh is sort of manipulating his scope, moving it right and left, and then trying to pass. And now you can see it's passed through. Can you see that very nicely?
Yeah, I think it's passed through.
Now the wire is passed through and I'm railroading my sphincterotome on.
So the technique he used was he had the assistant fiddle with the wire while he carefully did a anti-clockwise, clockwise direction of the endoscope so that wire could find a pathway into the pancreatic duct. This is very nicely shown.
So I was using a thermo wire and I'll exchange that with a stiff wire and then do the contrast injection to delineate the pancreaticogram. And accordingly, I'll do the next steps if it is dilated.
Also, addition can be made on a stent. In the pancreatic duct, we are now increasingly using the biodegradable stent. If there is a need only for a short time stent, the Archimedes one. But we'll have to see whether there's any need for any stenting in this case, or we can just get away by I think Rakesh is
And
now.
how you
Where is it?
decide for the biodegradable stent? The one lasts for, you have one lasts for weeks, one for days, one
Yeah.
for 1 week. Which
Yeah,
one you can use?
usually, yeah, if it's for a prevention or prophylaxis for pancreatitis, we use the one which is only for 4 weeks, the short one. So we have also ultra short one for 10 days. But if it is for longer period, as we want to use it as a stent for the particles to come off or for a stricture, then we use the longer version, minimum 3 months. So that's how we do.
So this looks
And how
dilated.
frequent you follow the patient with a fluoroscopy, or like every 3 months you do to see if it's this?
Yeah,
the
no,
stent is still
no,
there or-
we would go in, get a plain X-ray done after a month, and again repeat it after 3 months. So we'll know that the stent is dissolved.
Yeah.
If you have a good fluoroscope, if you have a good X-ray, that is good enough. But you can also, of course, do fluoroscopy. So Rakesh, you think some more contrast has to be given?
Yeah,
here?
we'll just put some contrast and delineate the
So
head
that
and
you
body.
can see asthma is huge. In this case, it's about maybe around same as the scope. So it's about 12 millimeters. 12 millimeters. Yeah. And then there's no stricture that I can see here, obviously.
Yeah.
It's a very dilated duct. So I think this patient probably will require do a good sphincterotomy and a balloon sweep. You can see some thick material coming out already.
Right.
So Rakesh, can you describe the technique of pancreatic sphincterotomy?
Yeah, so what I have done now is I have put in the stiff wire, and then I have, with the sphincterotome, I'm going to do the sphincterotomy, pancreatic sphincterotomy, and obviously my cannulotome is at 1 and 3 o'clock position. So what I'm going to do is gently, lift it. Oh, yeah. So now I'll be doing a gentle sphincterotomy. I don't need a large pancreatic sphincterotomy because I just have to push in the stent. But because I am contemplating for a balloon, so I'll do up to the first fold. Yeah, that's enough. Right. I'll just extend the sphincterotomy a little bit more, because the more bigger the sphincterotomy is, then the better will be the flushing of the residual fragments. So I leave it here, and then I'll take out the sphincterotome. I'll introduce a small balloon to flush out the adequately pulverized fragments, and then I'll put in a stent. So what I'm going to do now is take out the sphincterotome and then use a balloon to flush out the fragments. Can you give me a balloon?
So one of the things that also maybe dilatation you want to, one of the things that we've been doing asthma now in patients with chronic pancreatitis is do this sphincterotomy, not a huge one, but to do like a 5 millimeter like this case, and then use a Titan balloon or one of those hurricane balloons to actually dilate it. Now, the reason why this is important is that unlike a standard pancreatitis or a biliary sphincterotomy, most of these patients with tropical chronic pancreatitis we see here have a small prepapillary stricture.
Yeah.
And once we do a balloon dilatation with one of these hurricane or Titan balloons, then what happens is that you can open up not only the sphincter but also the prepapillary stricture.
Yes.
Okay.
So I'm using a Titan balloon from Cook, which is a 6 into 4 centimeter balloon.
So this balloon now dilates the sphincter and also dilates the prepapillary stricture.
Yeah.
And once that is done, then you know that any particles that are there, and you can see very nicely that the stone is completely gone here. It's pulverized, and that's the advantage of these modern lithotripsers that we have.
Yeah.
The size
So
of
now I'm using
the size is standard, or you have a bigger balloon?
No, we depending on the size, we can go up to 12 millimeters also. For a pancreatic duct, usually it's 10 millimeters, but you can go up to even 12 millimeters. So this is a dilated duct, so we can go up to 12 millimeters. In this
I'm
case.
wondering, can we do a sphincteroplasty, or we have to do sphincterotomy instead of
We don't do plain sphincteroplasty. The reason we don't do plain sphincteroplasty is that with plain sphincteroplasty, you don't get a big enough opening in the pancreatic sphincter. Plus, post sphincterotomy sphincteroplasty pancreatitis dangers are there. This is a sphincterotomy followed by a sphincteroplasty.
So
large balloon.
6 mm.
Yeah, you can now see the balloon on the fluoroscopy, now nicely dilated.
Yeah. So I'll wait for a minute.
The waste is gone.
So this will give you adequate drainage of the fragments, and also there will be a faster decrease in the intraductal hypertension. So this obviously merits a plastic stent, pancreatic duct plastic stent, because that will decrease the intraductal hypertension faster and also helps in giving a pathway for flushing of the fragments.
So there is no stricture as such asthma in this case. The reason why Rakesh was suggesting maybe a short plastic stent is for the fragments if they want to drain off. But you can also do a balloon sweep also. Rakesh can do a balloon sweep.
Yeah, we'll
do a balloon sweep. In this case, any of these tiny fragments that are there will come off.
Yeah.
But you can see this duct is quite dilated.
Yeah.
Yes, that is almost more than a centimeter,
Yeah.
1 centimeter.
So you can see that the material that's coming out asthma is typical after ESWL. It's not just pure pancreatic juices. Pancreatic juice mixed with a lot of fibrin type of material, small calculi. These whitish areas, what you're seeing, are small calculi.
Now the question here is, shall we just do a balloon sweep and leave it off?
See, I think we can see if balloon sweep is clear, then we can leave it off. So maybe we can do a balloon sweep. So
I think the advantage of the biodegradable stent, you just place it and leave it, and you don't have to go again and take it off.
Yeah, that's
Right,
it.
yeah.
But in this case, the
How
problem
expensive is the biodegradable stent? Is it expensive?
It's very expensive. It's not by Kuwait standard, but by Indian standards. It's expensive. So the thing also, Asma, is that in this case, I think just a good balloon sweep may be sufficient because there's no
You have
obvious great
A good
sphincter.
sphincterotomy, yeah.
Yeah. So we have been using this biodegradable mainly either for prophylaxis for post ERCP pancreatitis, and of course not. You can see the balloon now inflated. Can you keep?
Yeah.
Now can
Okay.
come down.
So you can appreciate on the fluoro, the balloon is inflated. I'm slowly coming down, doing a sweep. I don't expect much fragments
you
to
can see
come
all
out.
those material that's coming out. Ah,
Yeah.
fantastic. You see the mucus-like material.
Yeah.
So I think that didn't require anything more now, Asma. In this case,
So we can
everything
just leave
is
it
clear.
off.
We just leave it alone now.
Do you leave
Don't
it
this
in?
warrant. Okay.
But how is the you load? Is it easy to load the biodegradable stent, or is it difficult?
It's easy. It's very easy.
Very easy.
Yeah.
Very nice
So I
demonstration.
think, thank you. We finished the procedures. Again, we just come to our end of our time.